Okay, part 2, chapter 47. Now let's move a little bit further down the GI tract and talk about, we're going to do the gastric stuff and the duodenum, first part of the small intestine. So a couple of terms that I want you to know, because as a medical person you've got to use medical terms and not layman's terms. So you might see the word hematoemesis. Hemata being blood, emesis vomit, bloody vomit. Hematochezia, hemata being blood, chezia being stool, bloody stool. Melena. Okay, now here's you got to know the difference between these. This is this would be akin to like frank blood. So if you can see blood in the stool, it's called hematochezia. That's also known as frank blood, like your patient goes to the bathroom and they can actually visualize blood in the stool, or they can see streaks of blood on the stool. That's frank blood. But melena or occult bleeding does not show up as readily. That like melena would be like dark tarry stools. Occult bleeding would be a stool that looks normal, but then when you guaiac it comes up positive. So these, like frank bleeding and hematochezia, tend to be lower in the GI tract, like we're talking, you know, rectum, anus, maybe descending colon. But melena and occult bleeding could be anywhere along the GI tract. So you could have bleeding up in the stomach, duodenum, other parts of the small intestine, and it's not going to show up, and it takes a long time to finally get to the stool, and you don't see it right away, but it will show up microscopically. We're going to talk about being overweight. So you need to know the difference between morbidly obese, and overweight. And morbidly obese is somebody who has a BMI of 40 or more. Obese is 30 or more, and overweight is a BMI of 25 or higher. Normal weight should be 24 or less. Omentum is the covering of in the abdominal cavity. So you will, like if you're doing a big GI case, they have to like pull back the omentum to get to the gastric organ or the abdominal organs. A peritoneum is the thin layer that covers all the internal organs, and it would be similar to like you know when you make a plate of food and then you put saran wrap on it afterwards to keep it nice and fresh and all on your plate. That would be like the peritoneum. It kind of is like the thin layer of covering, whereas the omentum is more of like the fat layer of covering. Staturia is like fatty stool. This word meaning fatty or frothy stool. So if you've got somebody's got like, you know, like fatty foul stool, that would be the word for that. So those are just some words I want you to be familiar with, because when I go through the lecture, I want you to know what we're talking about. So it's really important when you're doing a GI assessment on your patient, and you'll remember that you always want to auscultate your abdomen and the GI tract before you palpate it, because you don't want to palpate first and have all of the gastric contents moving around and then auscultate. So auscultate first, and listen to what your patient is telling you relating to symptoms. So if you've got, your patient is complaining of pain in the left upper tic-tac-toe box, that could be a stomach ulcer, a duodenal ulcer, pancreas, because the pancreas sits right about here, biliary colic, the biliary tree goes between the pancreas and the liver. Over here you can have stomach ulcers, heartburn, pancreatitis, gallstones. We're going to talk about that during hepatic week. If they're over in the right upper quadrant, again you can have gallstones. Stomach ulcers can occur here in pancreatitis as well, because your stomach kind of sits here, your pancreas sort of sits here, and your liver sits over here. So, you know, like if you've got a stomach ulcer right here, you could kind of think that it's up in this area. Your kidney stones, urinary, urine infections, constipations over here, lumbar hernias, pancreatitis, appendicitis, which is weird because your appendix is down here. So this, if you'll remember, all of your small intestine is in here, and then it starts over here. You've got your ascending colon, but your appendix is right here. It does nothing. So this is your ascending colon, your transverse colon, your descending colon, and then into the rectum and anus here. So it's just kind of, when your patient's complaining of pain in these different areas, it's kind of important to know what structures are underneath there. It'll give you a good idea of maybe what's going on with your patient. So the next thing I want to talk about is gastritis and peptic ulcers. Another word for peptic ulcers is gastric ulcers or stomach ulcers. All those words are interchangeable. There are a lot of things that we do for our patients who have ulcers. Most of the time, an ulcer will go away on its own. Usually there's just one ulcer. Ulcers are painful, especially after somebody eats. It's really uncomfortable, so there's a lot of stuff that we can do before surgery. So there's a list of medications used to treat gastritis. Is just inflammation of the stomach when the sort of like the patient will be nauseated, vomiting. It's usually viral, sometimes bacterial. Usually tends to go away after about a day or two. Oh, you know what? Wait a second. My little guy, I put my thing right in front of what I wanted to talk about, but so the things that cause gastritis and peptic ulcers, again, smoking, alcohol use, overuse of NSAIDs, people that have been burned, people that are stressed. This is why anybody who comes to the hospital, we put them on H2 blockers and antacids. Usually they come in, we put them on Zantac or something like that, because people under stress tend to get stress ulcers. People with kidney and liver disease, people with trauma, they're all at risk for developing peptic ulcers. So we keep an eye on that. Once a person has been identified as having a peptic ulcer, then we treat it with the antacids. Now, sometimes when a patient has a gastritis, it can develop into or it can be caused by an H. pylori bacteria, the Helicobacter bacteria. This is what it looks like. And this is a little nasty little bacteria that can get into the stomach and can be the cause of a peptic ulcer. Not always, but if your patient is developing an ulcer and you're treating them with all the stuff that we have to treat them, it's not that difficult to treat. But if that ulcer doesn't go away, they might have to go in and have an EGD, an endoscopy, and get a biopsy and see if there's actually a bacteria going on in that stomach. It's known as H. pylori. And then on top of the peptic ulcer treatment, the patient also has to be on antibiotics. This is a very nasty little bug. And what happens is this H. pylori will come down into the lining of the stomach. They start kind of destroying the lining of that stomach, sending off hydrogen. So it's starting to affect the pH balance of the stomach. More tend to show up, just like any colonization of bacteria, and then it starts the destruction of the stomach lining, leading to a peptic ulcer. But if it's not identified and you just keep treating it with H2 blockers or proton inhibitors or something like that, it's not going away, this will continue. And patients who have H. pylori bacteria are at higher risk for developing gastric malignancy. So it's really important to identify that, and we treat that with antibiotics. So do kind of look at table 47.1 in your book. So peptic ulcers can show up anywhere. They are painful. We already talked about some of the causes for them. Here's an interesting thing. A lot of people think that peptic ulcers are caused by spicy foods or dairy foods or caffeine. That's not the case. There have been no studies that have shown that people that drink more coffee or lots of pop or have spicy foods are more likely to develop gastric ulcers. That's not true. Smoking, alcohol, and NSAIDs and stress, yes. So what an ulcer is just a break in the lining of the stomach. Now you can have an esophageal ulcer, you can have gastric ulcers, you can have duodenal ulcers, you can really have ulcers all along the GI tract. And another great table for this is 47.2 of your book about ulcers and what to do about them. Super common. You will definitely see patients who have ulcers in your practice. And so I do want you to know about peptic ulcers. Pharmacology is the easiest thing. First of all, lifestyle management first. So if your patient is overweight, if they are, pounding down the Motrin all the time, if they're smoking constantly, if they're heavy drinkers, get them to alter their lifestyle because that will stop it. And if that doesn't work, you might have to have surgical intervention. Now, the other thing that you watch for in your patients who have ulcers is you want it to repair itself. And it would be equivalent to having like a decubitus ulcer. Once you identify it, you start treating it, and then it should repair itself. That's your goal with a stomach ulcer. The thing that you need to be careful is if it bleeds or perforates through the stomach wall. So if you have an ulcer and it is a bleeding ulcer, if it's in the stomach and all of a sudden the patient starts vomiting coffee ground emesis, so they will vomit stuff that looks like coffee grounds, you've got something that's bleeding in the stomach. And the reason is when blood mixes with that stomach contents, it ends up looking like coffee grounds. So if your patient is vomiting that kind of stuff, they're bleeding in their stomach, and you need to treat them as if they're hemorrhaging. So you're going to increase their fluids, watch their heart rate, watch their blood pressure because they're hemorrhaging until you can get that bleeding under control. Then you might have to take them to surgery right away. If, however, the ulcer perforates through this way, now the bleeding, instead of coming out through the mouth, is going to bleed into the abdominal cavity. So the patient will start, their heart rate will go up, their blood pressure will go down, just like any other hemorrhage patient, but their abdomen can start getting really rigid. So if you have a patient where they have known peptic ulcer and they start, they get a rigid abdomen and all of a sudden their vital signs are getting all out of whack, they may have perfed through that stomach or esophagus or duodenum or wherever the ulcer is, and again, that person's going to have to get to surgery. But while you're waiting to get them to surgery, your job as a nurse, get them on oxygen, get them on fluids. So, peptic ulcers. Okay, so this is what it looks like from an EGD. As you can see in the duodenum, here's a little ulcer right here. And so it doesn't look like it's bleeding and it has not perforated through yet, but that's going to be painful, especially when food and stuff goes by there. So you're going to do all those things, like I said, to try to just get that healed up. This is what it looks like in the stomach. And again, you can see it's a little bit red and inflamed over here. It's got a little bit of a divot in it, but right now it doesn't look like it's going to perforate or herniate. Those are the biggest problems with your patients that have ulcers. The next thing that I wanted to talk about this in your book, this is another humongous problem in the United States, is the problem of obesity. Now, a lot of people and a lot of books are not including obesity in with the gastrointestinal section. They're moving it to the endocrine section because it creates such a metabolic impact on the patient when your patient becomes obese, and especially when they become morbidly obese. Both of these people are morbidly obese. They are more than 40. Their BMIs are more than 40. This is an extremely perilous situation for your patients to be in. So what we want to do is prevent it. So nurses need to be champions of healthy lifestyle living. You need to be a model of healthy eating, not smoking, not drinking, not being physically active, and role modeling that for your patients. Because the problem is, and we're seeing this younger and younger in the United States, the problem is when your patients start getting obese like this, they start developing a plethora of other problems. It will affect their heart rate, they're more prone to asthma, they're more prone to malignancies, they're more prone to hypertension, diabetes, stroke. They've got venous problems, they get skin disorders, musculoskeletal disorders, because the skeleton is designed to carry anywhere between 100 and 250 pounds depending on your frame. Well, all of a sudden you add all those extra weights, it's extremely hard on the joints. They tend to get osteoarthritis a lot more. So you really want to, one, prevent it in the first place. Once you identify somebody who is obese or morbidly obese, start implementing some lifestyle changes, some diets, they might need help with nutritional information, eating healthy fruits and vegetables, increasing their physical activity. When those things don't work, and we do have some medications, we don't have great medications for weight loss. Everybody is looking for that like magic pill. They want to just take a pill to lose weight, but whoever can invent that is going to be a millionaire. We don't have anything like that right now. It takes a lot of work, a lot of hard work, physical activity, and diet, which is difficult. But when those things don't happen, the patient can go for bariatric surgery. Now, I do want you to look at in your book about some the restrictions, like who can have bariatric surgery and who is not a candidate for bariatric surgery. However, what we're finding now is that patients who have bariatric surgery are actually doing really, really well. So the push now is for patients to actually have the surgery sooner than later. There's a bunch of different kinds of bariatric surgeries. A Roux-en-Y gastric bypass, it used to be pretty common, and what they do is they sort of cut the jejunum and then reattach it up here, and then cut off the stomach, or sort of just stitch off the stomach. And so when the person eats, it comes down the esophagus. There's only a little tiny pouch that has about a 20 to 30 milliliter capacity of food, and then it goes right into the jejunum and completely goes out and around the stomach. So what happens when somebody eats, they just can't eat very much because they only have like a 20 to 30 milliliter capacity for food. So that's called Roux-en-Y. There's other kinds, like there's a common limb where they just staple off part of the stomach, they staple off the end of the duodenum and sort of do a bypass. That's a common limb. This is in your textbook, I think, or something similar is like this in your textbook. There's a procedure called a gastric banding, where they go in and they just put a band around the stomach, and the same thing happens is that you just eat and there's just a tiny little pouch, and then it just slowly goes through there, and so their stomach fills up quicker. There's a vertical banding, there's a sleeve gastrectomy where they just sort of put a sleeve over. So there's a couple different kinds of procedures that they can do, but in all of them what they're doing is reducing the size of the stomach so the person just simply can't eat and as much as they used to. So there are certain screening things. One, they can't have an underlying endocrine disorder causing the obesity. They can't have significant psychological issues, like somebody who's got schizophrenia or something like that. They cannot be addicted to drugs or alcohol. They have to have at least tried to lose weight. And then once the patient has had gastric bypass surgery, and I should tell you, and your book doesn't mention this too much, but they're developing some methods now that are done laparoscopically, which is huge because like I showed you the pictures of those people that are morbidly obese. The problem with these kinds of surgeries is they make an incision in the abdomen and go in through kind of a major incision. The problem is the patients are so large, when they bring the omentum back together, there's not a lot of blood vessels in there. It's mostly just fatty tissue. Well, you've got a huge layer of fat those tend to not seal very well, so they're at major risk for dehiscence, for that wound to open back up. They're also at risk for pneumonia, atelectasis, because it hurts, and so they don't want to take a deep breath. So you have to teach them to splint that wound. But you still want them up walking, but the risk of that dehiscing is high. So they become a major postoperative challenge. And again, just based on their size, it is difficult for them to get up and use the restroom. And so then skin condition can be a very big challenge for the nurse. So postoperative care in these patients is huge. They can also develop this thing called dumping syndrome. So what happens after bariatric surgery, because of the significant alteration in the size of the stomach, and they're not entirely sure why dumping syndrome occurs, there's a couple different theories. Bottom line for you as a nurse is what happens is somebody eats, and then all of a sudden the food just slides through that GI tract really fast, and the patient feels lightheaded, dizzy, they get nauseated, sometimes they can start vomiting, and they feel like they've got to run to the bathroom, and the food goes right through them. And that's called dumping syndrome, and it's very common following these kinds of procedures, like up to 75%. So what we do in patients like that is, one, you have them eat small meals. Do not combine solid foods with liquids, so they need to stop drinking about 20 to 30 minutes before their meal, and then they just eat a small little amount of food. After surgery, they need to sort of lay like in a recumbent position, sort of like like a lazy boy chair is great, or like a semi-Fowler's position, so that they're not straight up, because that would use gravity to dump the food right down. So you want to have them laying down for 20-30 minutes after a meal. So those are some ways to prevent dumping syndrome, and certain foods that are high in sugar and things like that tend to cause dumping syndrome more than other foods. The other thing is, after a person has had the procedure, it takes about a year for the body to kind of be where it's going to be. So the fat, it takes about that long to dissolve and go away. Well, the problem is the skin that has been stretched out that much does not bounce back. And you'll know this, ask any woman who's been pregnant. After that, she will have stretch marks, and her skin will never go back to like it was. Just because in 9 months you've got this little baby out there. Well, imagine years and years of having, extended skin out there. So what happens is this big body, the big scoop, let me show you. I'll go back to this right here. See this big, I don't even, it's called a pannus is what it is, but it's right here. And that's a pannus, and you can see it kind of comes down even into the pelvic area. That typically needs to be removed surgically, and that's done usually about a year after surgery. A year after the bariatric surgery, they'll go in, usually a plastic surgeon, and they'll just cut that out. So skin, self-image, body image is a big deal for patients who are dealing with significant obesity. It's difficult interacting with people, it's difficult getting around, it's difficult moving, it's hard to get in and out of cars. Airplanes is a big deal. So there's a lot of psychological implications when you're dealing with a morbidly obese person, beyond just the physiological issues that they deal with. So do review chart 47.6 for a list of post-surgical interventions following bariatric surgery. That'll give you a little bit of a better idea of how we deal with bariatric surgery. So let's talk a little bit about gastric cancer. This is not a good cancer to have. This is similar to esophageal cancer. This is not a good one. So typically what happens in stomach cancer is, we don't have a ton of it here in the United States. It's very prevalent in Japan, it seems to be associated with people that eat a lot of smoked food, so people that have a lot of smoked fish and things like that in their diet, and with low levels of fruit and vegetables tend to have higher risk of gastric cancer. Again, smoking is a big culprit of gastric cancers. It's hard to identify because there's a lot of space for it to hide. Unlike like neurocancers, where creates headache right away, a stomach cancer can survive for a long time because there's a lot of places for it to go before anybody even knows that it's there. You can have stage 0, which is just in the mucosa, really hard to identify at that point. All the way to stage 4, where it's all through the layers, through the mucosa, the submucosa, the muscle, and the outer layer, and it's even going through, and now this is going to start metastasizing. And again, this is what it looks like on AGD. You can see that it's inflamed, large, and ugly. Once it's identified, typically, again, the treatment is surgery, and sometimes they will do, depending on where it is, how big it is, they can do a partial gastrectomy, they can do a total gastrectomy where they will remove the entire stomach, and then a person is going to be on a permanent feeding tube. Hopefully, if you can get them that far. So one thing that when I was working GI at U of M is, and this was back in the day where the treatment was, this was new treatment, but to have the patients use medical marijuana for this kind of a situation, because patients who have gastric cancer they lose their appetite, a lot of nausea, a lot of vomiting, and it's a rapid weight loss situation. But the patients who are using medical marijuana, 1, it reduces pain, and 2, it increases appetite. So in your patients who have this, that actually is a legitimate reason for your patient who does need medical marijuana, which is now legal in Michigan. This is actually a legit reason to do that, and they've had some success with that. So you want to identify it early, and then surgery is the treatment of choice, followed by radiation, and of course, if you've got this situation, chemotherapy, if it has already extended into the lymphatic system. So there you go. That was chapter 47. We're going to do one more. We're in chapter 48. We're going to go a little bit further down that GI track.